you. Next, I invite Dr. Archana Pradeep. She is a consultant ophthalmologist at Nottingham University Hospitals. She is a dedicated uvea consultant and a phacosurgeon, and she is also a training program in charge of East Midlands Ophthalmology Hospital. Okay. Over to you, madam.
Thank you, Risha, for the kind introduction. And thank you, KSOS, for inviting me and giving me the opportunity to be part of this remarkable conference. Can you hear me well there? Okay, fine. So when Risha asked me to present uveitis management and guidelines, I felt a bit challenged because, as you all know, it's quite a fairly vast topic, and to squeeze it into a 10-minute session can be a bit challenging, but I am undertaking that challenge for you, Risha. Anyway, so uveitis, as we all know, is correctly used, a term that's correctly used to describe inflammation of the uveal tract. But in reality, it encompasses a wide variety of inflammatory conditions affecting not only the uvea, but also the retina, optic nerve, and vitreous. And the prevalence of uveitis varies according to the geographical location, and 10 to 15% of the cases of total blindness worldwide is attributed to uveitis. And it can cause significant socioeconomic impact, as it mostly affects the working age group patients. So how do we define uveitis? It can be quite a confusing process because it can be approached in a multi-pronged fashion, and also with more and more newer terms being progressively added to our lexicon. Actually, coming up with a definition can be sometimes a bit perplexing. So you can define uveitis according to the anatomical area affected, like anterior, posterior, intermediate, so to say, behavioral, like acute, chronic, recurrent, etc. Etiological diagnosis, depending on the etiology, as in whether it's infective, non-infective, masquerade, idiopathic, eponymous definition like Fuchs and Posner-Schlossman, descriptive like punctal innate choroidal retinopathy or BSCR, and speculative like presumed Behçet's and possible sarcoid. So when you approach a case of uveitis and to diagnose and manage, you need to be very systematic and thorough and make use of all these entities to come up with a sensible diagnosis and management plan, making sure that you quantify the disease and see whether, first of all, whether you're dealing with a sight-threatening and or a life-threatening condition as well, because as you all know, systemic associations can be common in uveitis. I'm not going to go into detail regarding the anatomical classification, etc., but just wanted to get across this point because I've seen time and time again, referring clinicians saying that this patient's got posterior uveitis, but in fact, they are just having an anterior uveitis, which is complicated with macular edema or reactive papillitis, so to say. So the classification should be based on the anatomic site, but not based on the structural complications. Just going to skip through those because I'm sure you're familiar with all those. Just to get across that, please grade, quantify the disease, measure the disease. So grading you can do with all the scoring system right from the baseline presentation and throughout the reviews, so that you can see whether the patient is responding to treatment and whether you should be changing your management. So please do document it and quantify the disease. It is worth spend the time. Right, so how do we investigate uveitis? Or so to say, any clinical entity. Your principle should be minimum investigations giving us maximum information. So please don't throw a whole lot of battery of tests and you will be baffled because you'll be having to deal with a lot of false positivities, negativities, etc. So minimum investigations, giving us the maximum information. So stick to general tests common to most uveitis patients and specific tests relevant to particular type of uveitis patients. So as I mentioned when Natasha's talk was going through, we need to be aware before ordering an investigation, see whether this investigation is going to change my management or is it going to add an impact in this patient's care. And so therefore you need to be looking at the sensitivity, specificity, the positive and negative predictive value, and then interpret along with the history and the clinical signs to build up the diagnostic confidence that you are actually diagnosing this patient correctly. So for example, there are different levels of diagnostic confidences, like confirmed. For example, if you are having a confirmed microbiology or a histopathology report, you have a confirmed diagnosis. Presumed when you have strong supportive evidence and possible with no other evidence of another diagnosis, especially very much like Natasha's case. So there was no evidence of another diagnosis, it's possible sarcoid, okay? And we don't have the tissue diagnosis for confirmation. So what are the baseline investigations that we should be doing in a case with uveitis? I'm going to come to that in the next few slides. That not all cases of uveitis needs investigating, but if you are considering to investigate, what are the baseline investigations that we should be doing? So we have to start with full blood count, liver function tests and kidney function tests, although it might not be giving any clinching diagnosis, but it does give us ideas as, for example, eosinophilia in parasitic infection, lymphopenia in sarcoid, so to say, or neutrophilia in bacterial infections, etc. Liver function tests, it might be elevated in sarcoidosis, for example, if there is liver sarcoid. But again, that is a good practice because you can get a baseline result if we were to start immunosuppression at a later date. ACE, angiotensin converting enzyme, even though it's not a very sensitive or specific test, we still do include them as a baseline investigation, and anything above 100 has got good correlation with sarcoidosis. Syphilis, again, is a great imitator, so please do include syphilis in your baseline investigation. Urinalysis, such a simple, non-invasive test, but giving you worth a lot of information. And of course, also a chest X-ray. I did, listen to Dr. Anuradha's suggestion about HRCT, but in a UK setting, we will have to do chest X-ray first before to prove whether we need to do HRCT. Sometimes we might not pick up peripheral nodules and stuff in chest X-ray, but then I can, if the patient is symptomatic or if I can argue the case for an HRCT, then I can go ahead. But that's not as considered as a first line, just because of the NHS setting. Specific investigations, I'm not going to go through all this, but again, it will be history-oriented and clinical examination-oriented. For example, ANCA, toxoplasma, antibodies, quantiferon, etc. MRI head in demyelination, lymphoma, and neurosarcoidosis. And of course, chorioretinal biopsy and vitreous biopsies, as the case may need. So, when to investigate a case of uveitis? So, unilateral acute, new or recurrent, non-granulomatous anterior uveitis. In a fit young adult, no investigations are required. But it is a bit difficult to ascertain whether that patient you're dealing with is a fit young adult. So it might need a bit of a work before you can actually, label a patient as fit young adult. So most of the time people tend to just investigate because they can't be bothered, but you should be taking the effort so that you can prevent unnecessary investigations and then all these kind of false positive tests or whatever it is. A bilateral simultaneous anterior uveitis of any type or a granulomatous unilateral anterior uveitis in a fit patient, you still should investigate, starting with the baseline investigations that I mentioned. Intermediate uveitis again include the baseline investigation, but only consider neuroimaging if the patient has neurological symptoms or signs. So there's no point in just ordering neuroimaging, because most of the time intermediate uveitis can get reactionary papillitis element, and that might not be, something to worry about, and it will respond to treatment. But if there are any neurological signs, or if you're dealing with an elderly patient, please do consider neuroimaging. Acute unilateral panuveitis, yes, you definitely need to investigate, and also even consider doing a blood culture, vitreous tap and echo to rule out any endogenous sources. Necrotizing retinitis, of course, again, baseline test with a supportive tap results. Posterior uveitis and retinal vasculitis, as I mentioned, again, it's pattern recognition with directed investigations like TB testing. And also in patients in whom you're suspecting an underlying disease, please do not hesitate to refer to a physician, as they might require more detailed or invasive investigations. So what are the general principles of uveitis management? So set targets for achievement. That's why it's important to quantify and measure the disease. Gain patient understanding. You need to develop that rapport with your patient, because as you can see in those cases that you presented, some patients are not adhering to the treatment, they just stop. They might not be knowing that these are chronic conditions which need fairly lifelong treatment, and that can modify their systemic risks, etc. So time spent is well worth spent, because the patient compliance is important. It actually will help you. Anyway, so I'm gonna, again, also please don't forget dealing with visual loss. You might have to support the patients with rehabilitation, etc. So treatment, again, mainly medical and surgical. Medical, as you know, with steroids, topical or periocular, intraocular, and systemic. And then the second line would be immunomodulatory treatment if they are not responding to steroids, or we can't maintain remission with lower doses of steroids. And surgery in uveitis patients, as a general principle, you need 3 months of quietness, and we might have to condition them accordingly in their pre- and perioperative periods, and also close post-op monitoring for flare-ups, and continued remission might be required. And these cases can be quite challenging as well surgically. Just wanted to go through a quick flow chart for managing non-infectious anterior uveitis. So if it's anterior uveitis, you look for, are there any structural complications associated with it, like macular edema? If there is, then you treat with systemic and topical steroids, of course, after ruling out infections. If there is no macular edema, then you treat accordingly with topical steroids, and might need staged mydriasis or subconjunctival steroids to break the posterior synecdoche. And none of them working, then you might have to escalate to the systemic route. Just to highlight this point, that if the patient is having more than 3 episodes of anterior uveitis per year, please do consider uveitis specialist referral for consideration of immunomodulatory treatment. Intermediate uveitis, again, if there is dense vitritis, if there's macular edema, again, you treat accordingly with systemic steroids or periocular or intraocular steroids. If there is no macular edema, and you look at if there is vitritis causing reduced vision. If there is, again, you go down the other route to systemic steroids. If not, you can just use topical steroids. So basically, if there is no vision-threatening element, observation might be considered as well. Do I have time?
Time is over.
Yeah.
One more slide.
One more. I'm just gonna.
No. Time is over.
Time is over. Okay. Just wanted to show you quickly one slide about the newer developments. So newer and newer targeted treatments are coming along, biologics and biosimilars, and the role of gut microbiome, which is the gut-eye axis, has been extensively explored, and it is the era of precision medicine. But at the same time, we need to look at the cost effectiveness and feasibility. So all these microbiome signatures and the cytokine profiling, whereby you can see Many of the uveitic entities have like unique protein profiling and some common cytokine signatures. Some of the microbes in the gut can actually act as risk factors or even confer prevention of uveitis. So all these are exciting areas coming along, and actually we can, using all these together, pool data, we can actually even prognosticate whether this patient is going to get relapses, are they going to respond to particular treatment, etc. So just about the precision medicine, and I'll be done. So when we have the same patient with same diagnosis and they receive the same treatment, we do have some people responding to the conventional treatment and some people not responding to the conventional treatment. People who are not responding to the conventional treatment, with the new proteomics, metabolomics, all those pharmacogenomic testing, you can actually determine their genomic profiling and see why they're not responding, and then develop targeted treatment to treat. So future is bright. And with all these novel technologies emerging, we would be able to deliver not a reactive, but a proactive, predictive, and personalized treatment for our patients. Thank you for your time.
Thank you, Dr.